Okay, this will be a short lecture finishing up pediatric respiratory disorders. Towards the end of the PowerPoint presentation, we're getting into the chronic respiratory disorders in pediatrics, specifically asthma and cystic fibrosis. There's a role play activity for an asthmatic patient that I will post to your course in Ivy Learn. You can look over that with the answers attached. So asthma, you're going to want to be able to answer the questions listed on this slide about asthma. A lot of this is a med-surg review for you guys with real no differences for pediatrics, and the differences that we will talk about are the things that I want you to remember for this course. But you're going to need to know what is asthma, what are some specific triggers to asthma, so you can provide appropriate education to parents and children as far as how to identify those triggers. How might an asthma patient present? How is it diagnosed? And then how do we manage a child's asthma? And the next few slides will kind of help discuss this. Back to the diagnosis part, the most accurate test for diagnosis of asthma is pulmonary function test, which we'll discuss this a little bit more in detail in a later slide. Management is based upon severity of the asthma, peak expiratory flow rate, which we'll talk about how to measure that. That tells us if they do it daily, that tells us if their asthma is stable or if it's getting worse, and then it also tells us how to manage that asthma. And then the medications based upon their peak flow meter readings. Asthma diagnosis. So I said the most accurate test for the diagnosis is a pulmonary function test. This is done at diagnosis for a baseline, after treatment is done at that initial visit, and then yearly to kind of keep the, see how the child's doing based upon their baseline data. Peak flow meter, I said this is the device that kind of tells us how stable the child is and how well their current medications are managing their asthma symptoms. This is a link to a website with a short video on peak flow meters. I'm going to let you watch that on your own time. Prior to the peak flow meter, you want to educate the child and the parents to use it at the same time every day. Ensure that the marker is zeroed before the use. The child wants to stand upright. Remove all gum and food from the mouth. Close lips tightly around the mouthpiece. I have one here, it's hard for you to see. Some of them are bigger, rectangle-like substances. This is a small one. But if they zeroed the number here, they put their mouth all the way around it, and then it's how much air they can exhale quickly. So I take a deep breath, put my mouth around it, and then wherever that number goes, that's my peak flow meter. Blow it out hard and as quickly as possible. Afterwards, read the number on the meter, which we just talked about, and then tell the child and the parents to repeat 3 more times, waiting 30 seconds between attempts. They're going to record the highest number out of all of their attempts. That is a peak flow meter. Here's a picture of a peak flow meter too that looks slightly different. This asthma action plan, I will upload it to your course so you can see it, because it's kind of hard to see in this slide and determine what the writing actually says. But it's basically an asthma action plan to let the child know, let the parents know, let the care provider know how well our current treatment is going and what they need to do in relation to that. So if the child is in the green area, means they're doing well, breathing is good, no cough or wheeze, they can work and play, and they sleep well at night. Their peak flow meter is at 80% or greater from their personal best. If the child is doing well, they may only have a PRN inhaler ordered, such as albuterol, or they may be on a control medication, but that control medication is currently doing its job. We don't need to do anything else. If the child's in the yellow zone, that's a caution. area, it means they're getting worse. Symptoms could include some problems breathing, coughing, wheezing, or a chest tightness, problems working or playing, and they wake up in the middle of the night. Their peak flow meter reading would be in between 50 and 80% of their personal best. They would need to continue their current medication, so if they're on a PRN medicine for attacks, or if they're on a long-term control medicine, and plus they may consider adding some medications in this yellow zone to better treat or put them back into the green area. If they're in the red zone, lots of breathing problems, they can't work or play, they're getting worse, and the medicine in the yellow zone is not helping. Their peak flow meter is now less than 50% of their personal best. They need to continue their other medicines, but they're also going to consider adding medicine. We do not want these patients in the red zone. Make sure if they're still in the red zone after 15 minutes of medication administration that they contact 911 or call the ambulance. So that's what the asthma action plan is, kind of for the parents to take home so they have something to follow if things happen. Now we'll get to certain medications here in just a second, but the medications can be administered in various different ways, and that's what the next couple slides are going to cover. A nebulizer, you all are familiar with what a nebulizer is. Really the only difference in pediatrics is sometimes it could be hard for these kiddos to keep the nebulizer in place for the 10 to 15 minutes it may be required to stay on. So using fun nebulizer machines or mask may help. Having the parent hold the child, things like that may help intervene and help the child do what they're supposed to in order to inhale the appropriate medications. And again, there's a video here that you can watch about nebulizer treatments. Meter dose inhalers. There's a video attached to this one as well. So again, there's various ways that you can use a meter dose inhaler. With a spacer, it's recommended for young kids because they have a hard time sealing their mouth around the actual inhaler. So you'll see the spacer here in the picture. There's a method where they can hold it 1 to 2 inches from their mouth and inhale, and then actually put the inhaler in their mouth. They want to shake it really good, but prior to use, inhale, exhale, take a big deep breath in, let it out, and then they're going to put that either spacer or inhaler in their mouth and take a slow, deep breath in as they compress the inhaler, so they're inhaling all of the medicine. Dry powdered inhalers. I don't even have this slide on my notes. There's a quick little video here for you to watch for dry powdered inhalers. It's basically the same. They do not want to shake the medicine before administering, so that's one of the differences in between that and the meter dose inhaler. So specific medications, ATI breaks them down: short-acting, beta-agonist, long-acting, and then steroids. So basically what I want you to get out of that is if we're having an acute asthma attack and we want to better that patient immediately, we want a short-acting beta-agonist such as albuterol. And most likely it's going to be administered through an inhaler. If you have asthma yourself, you probably have a rescue inhaler at home. It's a short-acting bronchodilator used for acute exacerbations or prevention of exercise-induced asthma. So if exercise is one of your triggers. Tremors and tachycardia are common side effects. So you're going to want to educate the patient that increased heart rate and tremors is normal. Again, long-acting bronchodilators are used to prevent attacks. It is not something that's given for an acute asthma attack. Corticosteroids is an anti-inflammatory that's given to decrease airway inflammation over time. Don't think of corticosteroids as a short, acute attack medication. It's more of a long-term control medication. If it's inhaled, so it can be given orally or can be inhaled. If it's inhaled, the patient's at risk for fungal infections of the mouth, so they're going to want to rinse their spacer out and mouth after each use of the steroid inhaler to prevent the fungal infections. And if it's oral steroid, make sure they give with food. And also you want to educate parents and children about appropriate tapering off of steroids as well. There is a case study on cystic fibrosis, a Let's Play House case study on cystic fibrosis that I will upload to your course. You can look over that and try to answer those questions after watching this. Cystic fibrosis, so just quickly you're going to want to answer what is it and what do we normally see in cystic fibrosis patients. So back to what is it, it's a respiratory disorder and it's inherited from, it's a mutated gene that's inherited from both parents. It's a recessive disorder, so if both parents are carriers and do not have the disease, they both have to be carriers of the gene in order for the child to get cystic fibrosis. What do we normally see in cystic fibrosis patients? It causes very thick mucus, which leads to mechanical obstruction of multiple organs. It leads to respiratory problems. The pancreas is one of those organs that gets obstructed, so it doesn't produce the insulin, or it may not do it appropriately. So if there is such thing called cystic fibrosis diabetes, a lot of your cystic fibrosis patients will be put on insulin. The oral diabetic agents are not effective in this type of diabetes. They get vitamins, routine vitamins A, D, and E. They may have a loss of appetite, poor weight gain, failure to thrive because they can't digest the fat-soluble vitamins, and the loss of appetite, and the trouble breathing, and everything's thick. They get constipated, so their stool becomes thick. Sometimes this is the first indicator in your newborns that cystic fibrosis may be present, is they have meconium ileus, which means their meconium never passes because it's thick. Here's a picture that will help you remember some of the treatments, medications, symptoms of cystic fibrosis. Here's a video on some of the testing that's done to diagnose cystic fibrosis. So in the newborn screen, so we talked about the heel stick that's done before the baby goes home from the hospital that tests for rare disorders. Some states that includes cystic fibrosis. Now it doesn't mean that the child has cystic fibrosis. If that comes back positive, they may send them for further testing. Sweat chloride test is the initial screening test done to measure the amount of chloride in the skin. If it's greater than 40, in infants less than 3 months of old, that's suggestive of cystic fibrosis. And it has to be greater than 60 if the infant is greater than 3 months of age. They may also do a stool culture for presence of pancreatic enzymes. Those pancreatic enzymes in cystic fibrosis patients have to be artificially replaced in those patients. They may do pulmonary function tests because of that thick mucus to see what kind of lung involvement we have. X-rays if they suspect a meconium ileus, so if the baby hasn't passed the meconium yet. Treatment could include respiratory treatments to help with the lung involvement, chest physiotherapy, oxygen administration, small high-calorie meals. Pancreatic enzymes at all meals are required. Encourage fluid intake, monitor blood glucose. Antibiotics may be prescribed for secondary infections related to that thick mucus. If they have really thick mucus, it holds onto that bacteria longer. And then specific medications for all of these complications are listed in ATI on page 106 to 107. Back to the sweat test, and there's a video here that will show you that. It's abnormally salty in cystic fibrosis patients, so if a parent reports, well, I've been kissing my child and they taste really salty, that could be an indicator. There's an electrical device that stimulates sweat production. It's collected from 2 different sites for an adequate sample. For the pancreatic enzymes, it's administered within 30 minutes of eating a meal and any snacks. Also, vitamins A, D, and E are administered. Pancreas is not sufficient. So that's why these have to be administered with all meals and snacks. Dosage of these pancreatic enzymes and vitamins is done by stool characteristics. So we have to increase these if the stool is loose and fatty, and we have to decrease those if constipation is present. You can swallow or sprinkle these pancreatic enzymes on food if the child doesn't want to swallow the pill. This is a really cool video. I think it's about 7 minutes long, about a child living with cystic fibrosis and kind of a day in the life of that child. The percussion vest that they have to wear, all the pills and all the medications they have to take, the cost of that. So I really want you to click on that link and watch that. This is a video on chest physiotherapy, which helps break up that thick mucus. And then the rest of your PowerPoint slides go over the questions with the answers on the bottom, so I'll let you do that on your own time. Think of long-term cystic fibrosis. Infection prevention is huge, and respiratory management, because a lot of these kiddos over the long term of this disease will start to show the chronic signs of respiratory distress, such as clubbing of the fingers, the barrel chest, poor weight gain. They have thin extremities. So think of what a patient that's being diagnosed with cystic fibrosis may show up with: meconium ileus, thick mucus, sweaty, salty sweat on their skin, and then the long-term patient, a patient 20 years later, maybe barrel-chested, thin-armed, thin-legged, clubbed fingers, stuff like that.